Thank you very much. So good afternoon, everyone. I've been given this task, had to step in for a colleague of mine last minute. So I'm going to spend the next half an hour talking to you about why bruising in children is important and the challenges that you may face when assessing a child with bruising. Particularly focusing on what are the key features of a bleeding history in relation to a child that may help you in coming to a diagnosis, and the interpretation of laboratory investigations dependent on the age of the child. I'd like to finish off with a few case studies to keep you all engaged, and I hope you will participate. So the challenges when you're faced with a child with bruising. So bruising in children is relatively common. For those of you who have children, you'll know that children are covered with bruises due to normal activities, playing around, falling in the playground, or due to accidental trauma, such as falling off their bike or fighting with their siblings. But what's most significant is that bruising is also a sign of non-accidental injury, and of course, of an underlying bleeding disorder. And the assessment of a bruise really relies on the plausibility of the explanation that is given as the cause of the injuries. And to make a judgment on this requires experience. And thankfully, this is mostly done by the pediatricians, but as hematologists, we may also be asked to comment as to whether we think the bruise is appropriate. And I'll talk about that in this talk. The interpretation of laboratory investigations may also not be as straightforward, because blood sampling in children is not straightforward by any means. Asking for repeat samples is even more difficult. And also, given that age-appropriate references ranges are not always available. It's also important to consider that mild bleeding disorders may sometimes be assumed as the cause of the bruising, but in fact, there may be underlying concerns with regards to non-accidental injury. Also, a family where there is no history of any bleeding disorder may have to go through lots of steps with social investigations before the bleeding disorder is actually confirmed. And this can, of course, cause stress and anxiety to our families and patients. And you may have come across patients who have presented in this way. So what do we already know about bruising in children? So there is some studies and some literature which has looked into the number and pattern of bruising in healthy children as compared to those who present with non-accidental injury. We know that as children get older, they are likely to have more number of bruises as they become more mobile. We also know that certain sites, particularly around the face and genitalia, if you see bruising in these areas, this should raise alarm bells, as this is a sign of non-accidental injury. We know that young children are the most vulnerable, whether it be in relation to an undiagnosed bleeding disorder or to non-accidental injury. So what is age-appropriate bruising? Well, bruising in pre-mobile children is extremely uncommon and in any scenario would warrant investigation. So by that I mean children or babies who are not even rolling, let alone sitting up. If you see bruises in these children, then this should raise concern. Once children become more active and are mobile, then the bruises that you're likely to see are those in the front of the body or in bony prominences, such as the knees, elbows, lower limbs, arms, or in their buttocks. So when they fall down, they'll land on their buttocks. And it's commonly to find bruises in these areas. A recent study that was just published in the Archives of Disease in Childhood looked at the pattern of bruising in preschool children with inherited bleeding disorders. So this divided the children into 3 developmental age groups. Those that are early, so pre-mobile, those that are early walking, so beginning to cruise or stand with some support, and those that are fully mobile. And it looked at the number of bruises in each of these developmental stages over a 12-week period. And it found that children who have bleeding disorders are likely to have more bruises than those that don't have bleeding disorder. And the difference is most marked in the pre-mobile developmental stage. It also found that the children with severe bleeding disorders have significantly larger bruises as compared to those who do not have a bleeding disorder at all developmental stages. And it found that the location of bruises was different in those with a bleeding disorder as without. So it was more commonly found that children with bleeding disorders would have bruises on their trunks, buttocks, and limbs. Importantly, the study also found that in all of these 3 developmental stages, bruises in areas of concern, such as those around the face and genitalia, was rare. So that even if a child has a bleeding disorder and presents with bruises in these areas, this should be investigated appropriately, as this is a sign of non-accidental injury. It also states that children who have mild to moderate bleeding disorder and are in their premobile developmental stage yet present with bruises, it cannot just be assumed that their bleeding disorder is a cause of this, and it should be investigated. So when assessing a child with bruising, the context of the history is extremely important. The age of the child, the nature of the bruising, so where the bruise is, the location, its size, and its number, and the type of bruising that you might see. So, for example, petechiae, which we commonly see in immune thrombocytopenia, is different to having ecchymosis or hematoma, which may be a sign of an underlying bleeding disorder. It's also it's important to have an idea of the other history in terms of, is a child well or unwell? Have they presented with a coinciding viral infection, for example? Is this a child who's thriving, or is this a child who has multiple nutritional deficiency? Is this a child with liver impairment or other gastrointestinal problems that may explain its deranged clotting? Is this a child who has presented several times to A&E with multiple injuries? Again, that would be a sign concerning for non-accidental injury. Family history is, of course, very important. Moving on, it's important to assess the response to any hemostatic challenges that a child may have had. Now, children do not have many hemostatic challenges, so it's very important to ask particularly directed questions to understand any bleeding or bruising that they might have had. So if this is a baby, it's important to ask about umbilical stump falling off, and was there any excess bleeding or bruising in relation to that? Did they bruise following intramuscular vitamin K, which is something that most children in this country have? The Guthrie test is done at about 7 days old. This is a heel prick test, and again, some children may bleed excessively or ooze for a long period of time if there was an associated bleeding disorder. So it's important to clarify this. Some children may have circumcision, and that might be the only surgical exposure they've had. And so, again, this would give you a clue as to whether there was any bleeding or bruising that was abnormal. In infancy, children will certainly have some teeth. They might have lost their tooth, so it's important to clarify if they had any bleeding or bruising that was abnormal in relation to that. Nosebleeds, again, quite commonly seen in children, but whether they're prolonged, whether they're persistent, and whether they're from one nostril or both nostrils, again, these questions may help you in your diagnosis. In infancy, again, children should have had all their preschool boosters, so that's multiple, at least 3 or 4 occasions where they would have had intramuscular injections, and if there was any abnormal bruising, parents would probably have picked up on that. They would certainly have had many falls, and you could ask if they had any prolonged bleeding from cuts or grazes. As I said earlier, very few children have surgical exposures, but still important to ask if they've had any surgery or any dental work that led to any abnormal bleeding or bruising. And when it comes to laboratory investigations, and when you're asked to advise on these, the crucial thing is to emphasize the importance of the way the sample is taken and the technique in which it is obtained. So it cannot be a squeezed sample from a heel prick. It can also not appropriate for it to be taken from a central line which has got heparin contamination. And it has to be a free-flowing venous sample. And very important for us to stress that, because otherwise you'll end up with results that make no sense whatsoever. So if you have a child with bruising, you'd start off with a full blood count and a blood film and a baseline clotting screen. If the PT and APTT was abnormal, you'd go on to do some correction studies and specific coagulation factors depending on what the abnormality was. If the APTT was prolonged, you could do von Willebrand studies. If there was no correction, you'd move on to look for an inhibitor, which is possible and seen most in relation to infection in children. If none of these showed any abnormality, you'd go on to do some platelet function studies. But this again is quite difficult because it involves a large volume of sample that has to be sent to the lab quite quickly, and that's not always possible. And certainly in neonates under the age of 1, we don't recommend platelet function studies. If this is a child that is being investigated for non-accidental injury, factor 13 may sometimes be a part of those investigations. So moving on to the interpretation of the laboratory results, it's important to bear in mind age-appropriate reference ranges. We all know that coagulation factor synthesis occurs in the liver and it requires vitamin K. So there are different normal ranges for term and preterm neonates. And you can see this table is just an example of the different ranges, both at term and preterm. And the further or the extreme preterm infants, we lack any sort of normal reference ranges in this group. So it can become quite difficult when you're asked to interpret the abnormal clotting in these age groups. This is a graphical representation of the same reasons why the PT and APTT are prolonged in preterm and term neonates. So these are your vitamin K dependent factors 2, 7, 9 and 10, which at term are low and by 6 months can reach normal ranges. The more preterm you are, the lower these levels are. And so it's important to have some concept or some understanding of this when you're asked to interpret coagulation results. Other coagulation factors, again, can be low at birth, such as factor 11 here. And again, the more preterm you are, the lower these values, and they reach sort of normal values, normal adult range values by the age of 6 months. So I'll move on to share with you a few case studies, which are all, all real case studies that you may have come across as well. So this is a 2-year-old girl who presents to her local hospital. Her parents are concerned that she has several bruises on her shins and arms. She's just started nursery and they've noticed that she's started to have a few more bruises than are normal. She's picked up a few coughs and cold while she's been at nursery, and she currently has an ear infection, a little bit of a fever, but is otherwise well. There's no real family history of note and no past medical history. Is there anything else that you would like to know, or what would you advise given this history? Look for non-accidental injury. Okay, so this is a child who's presented with bruises. So apart from the bruises on the shins and arms, there's some on the face. So you're right, that should raise concern. So in pediatrics, we're very hot on the non-accidental injury, and that is escalated. So you investigate for that, and alongside that, this child then has some further investigations. So she has a blood test. And her PT is prolonged, as is her APTT. The laboratory does a 50-50 mix. There's a little bit of correction, but not significantly. The lab goes on to do some factor assays, and here are the results. And what would you suggest now? So you're called as the hematologist to advise on these results, and how do you take this forward? Okay, so someone has commented that she has an infection and she might have acquired some antibodies that may be affecting your tests.
Can I ask how the sample was taken?
It's a free-flowing venous sample, but absolutely, it's important to ask how the sample is taken.
Is there any other history? You haven't commented on the other history, pill, vaccinations, etc.
Yeah, so important to ask because she's 2, so she would have gone through all of those steps, and there is no previous history of any bruising that's abnormal.
Factor 2 result at all?
Factor 2 is currently cooking in the lab. We don't have a result, but has been test requested. So those are all the questions that I asked as well when I was asked to interpret these results. So I think hopefully you all agree that this is a well child, otherwise no history of bleeding or bruising. Some concerns there might be non-accidental injury, but the family is very appropriate, has brought their child in when they've been concerned. And given the history of infection and both prolongation in PT, APTT, low factor 8, 9, 11 and 12 doesn't make any sense and can only be as a result of an acquired inhibitor in a child who has an infection. So the child was kept in for observation overnight, was very stable, no further symptoms of any bleeding or bruising, was sent home with some advice as to if there was any bleeding or bruising to come back, given tranexamic acid in case there was any signs of active bleeding, and advised to come back to clinic in about 4 weeks. So when she came back to clinic in 4 weeks, the parents reassuringly said that they'd noticed the bruises had disappeared. There were no new bruises, which in itself is a telling sign. So, of course, we did repeat the results, but the history alone is suggestive that everything has resolved because she was extremely well. So her repeat test 4 weeks later, her PT and APTT are normal, and as you can see, all her factor results are normal as well. Okay, any questions on that before I move to case 2? Fine. Case 2. This is a 5-month-old Pakistani girl who was born at Tam, and her parents bring her into her local hospital because she has a bruise on her anterior chest wall. And it's thought this may be a rib fracture. She goes on to have an ultrasound that confirms that this is indeed a hematoma, about 2 centimeters by 3 centimeters on the front of her chest wall. She has a skeletal survey, which does not identify any fractures, and there's no family history of any bleeding disorders. So how would you take this forward? Consanguinity, it's a very good question. And yes, the parents are consanguineous. But what would you advise the pediatric on-call team who have called you for advice on investigation of this child who's presented with an abnormal bruise? Full blood count, blood film? Coagulation, yes. Full blood count, blood film are normal. The coagulation results are here. PT is 11.6, APTT is prolonged at 58.6. Fibrinogen is normal. The factor 8 is 0.01. Factor 9 is normal. Factor 11 is normal. Von Willebrand, yes. These are the von Willebrand results. So this is a girl who has type 3 von Willebrand disease. The parents are heterozygous. They have borderline low sort of levels, and she clearly is homozygous for the mutation. So this is a new diagnosis of type 3 von Willebrand disease. At the local hospital, when we were called about this, everybody was concerned this girl has hemophilia A, which of course is unheard of. And how do you manage this girl? So we said, just hold on, she's well, keep her in, observe her, and we'll do some factor assays in the morning, which we did. So my final case is one more commonly seen, and you may have come across a case like this. Is a 1-year-old boy who's learning to walk. His mum is concerned that, again, he has a lot of large, lumpy bruises, particularly on his legs, his arms, and his buttocks. And she's just not happy. He can stand, he can cruise a little, but he keeps falling a lot, and she's just worried about these bruises. So she takes him into the local hospital. No family history, again, of relevance. And you're asked to comment on what investigation should this child have. So baseline clotting, I hear people say. So he has a baseline clotting. These are the results. PT is normal at 11.2. APTT is 85. factor 8, 9, 11. So these are the results. So this boy has severe haemophilia A. This is one where there was no family history. When we went to test the mother, she indeed is a carrier and has the same mutation as the boy. But again, you can see the anxiety that is created when these families present to A&E with concerns with regards to bruising and are investigated according to the non-accidental injury as is appropriate also, but in some cases there may be an underlying bleeding disorder. So just to summarize, as I say, the diagnosis when assessing a child with bruises is really in the context of the proposed history, as well as the interpretation of laboratory investigations. And it's really important to bear in mind that there are age-appropriate reference ranges and there are some differences. And of course, if there's any doubt or, always discuss with your pediatric hematology team or send the child for further investigations to a tertiary center rather than having to repeat lots and lots of bloods locally, which is often distressing for both the patient and family. Thank you very much.